But we'll get started. Thank you guys for coming. Thanks, Liz, for having us.
Thank you.
So I'm from Avera at Home. My name is Sadie. I work for home health and I do hospice. And my coworker, I'll let her introduce herself, but Michelle, and I'll let her tell you guys a little bit about her, and then Melissa. So together, we're each gonna visit with you about kind of how we relate to end-of-life planning care or hospice or advanced directives, and hopefully we could tie it all together by the end. To get it started, everyone's welcome to cookies, brownies at any time. There's water. Hi, come on in. Bathrooms are right down the hall, and we should probably get you guys out of here in about 45 minutes or so, and there will be room for questions at the end. So feel free to, if you have a question, feel free to ask also. And then before you guys leave, we will have forms and papers. If you guys want further information, Michelle will explain what she's brought. But we also just got other stuff that you're welcome to grab at the end, okay?
Thanks, Sadie. And so I'm Michelle. I'm a social worker with Avera at Home. I primarily work with hospice patients, and I've been doing that for about 7 years, and have gotten to have some experience help guiding patients through advanced directives and that part of their care. So
I'm Melissa Schlowski. I'm a nurse practitioner with Avera Palliative Medicine. I also work with the hospice team and do recertification visits for them. So I get a little bit of both worlds. I think I will start off. We're going to talk about what palliative medicine is. In general, palliative is a baby as far as medical specialties go. Most people, when you say palliative medicine, they say, I don't know what that means. So we are going to go over that tonight. So our goals are to talk about what palliative medicine is, when and how palliative can help, understanding advanced care planning, code status, and then the difference between palliative medicine and hospice. Those, they get confused a lot, and we'll clarify what's what. So what is palliative care or palliative medicine? We use them interchangeably. So it's an interprofessional specialty. We focus on symptom management, quality of life, relief of distress for patients and their families. The focus is on improving quality of life for patients living with a serious illness and living well. We practice in multiple settings. We have outpatient clinics. We see patients in the hospital. And currently, we also travel out to nursing homes. In some areas, palliative medicine is delivered in the community like a home health service. We wish we had that here in town, but we do not yet. So the palliative care team, I said it's a whole team, and it really is composed of physicians. Here at Avera, we have a physician director out of Sioux Falls. Her name is Dr. Arneson. She works in the Prairie Center in one of the cancer clinics and also advises us. We get to meet with her weekly. There are 2 of us that are nurse practitioners that see patients. We have a full-time nurse and a part-time nurse. We also have a social worker that works with us, and we work with the chaplains at the hospital as well. That's the actual palliative medicine team, but we also collaborate with everybody else that's involved in your care. So whether that's your primary care physician, nursing home patients, that could be the aides that are taking care of them on a daily basis, nursing staff, dietary therapists, volunteers, whoever's involved in your care and knows you best. So who benefits from palliative medicine? So I said it's for anybody with a serious illness. That can be anything from cancer to chronic illnesses like COPD or heart failure, dementia, people with chronic kidney disease on dialysis, and then progressive neurological disorders, ALS, Parkinson's, multiple sclerosis. All of those diseases have symptoms that go along with them that can be burdensome. They change your life. And so the goal of palliative medicine is to help alleviate that symptom burden and to make life as good as it can be with that serious illness as it changes. When is it good to see palliative medicine? Early. Early is better. So to be able to get all of the benefits that we know palliative can provide, seeing somebody at the beginning of their disease trajectory is much more effective than at when things are falling apart. Lots of studies have now been done on palliative medicine and have shown improved quality of life for both the patient and their caregivers, actually. Improved mood, decreased symptom burden, improved survival rates, actually, of cancer and other illnesses, and improved outcomes at end of life. So palliative medicine services, we do a lot. So the first thing we talk about is symptom management. We can help with pain, shortness of breath, appetite, nausea, bowel management, sleep, mood. Some of those things are chronic. Some of them are associated with treatment for a disease, and we work with all of it. We also do a lot of planning. So we figure this out together. We want to help you make a plan for your care. So we take time to learn about you, what your preferences are, what your family is like, what your life is like. The goal is that we understand who you are and what's most important to you, so we can help guide you in making decisions that best reflect your hopes and wishes in the future. And then we're also helping things change. So our social work team does a really great job of helping support people when it comes time to transition. Sometimes that means things are going really well and it's time to go home. And so what support services do you need in the home to make you successful there? Sometimes home isn't working, and so are there services we can put into place to keep you at home longer? You know, is it time to look at assisted living or the nursing home? They also can help with navigating financial issues, available benefits, legal concerns. They're a really great resource. And then we talk about advanced care planning. That's another big part of what we do. So advanced care planning encompasses goals of care, again, what's most important to you in your health care, talking about living wills, medical power of attorney, and code status. So advanced care planning identifies your preferences for healthcare decisions that may need to be made in the future due to changes in medical condition, injury, or if you're not able to make decisions for yourself. Advanced care planning discussions regarding goals of treatment and complex medical decisions are essential to ensure patient preferences are honored. If we don't talk about it, we don't know, right? These are sometimes really hard conversations to have. We don't like to think about our own mortality. We don't like to think about the mortality of people that we love sometimes. And so if we don't talk about it, everybody guesses. And that's really hard if you've ever been the person that's been put in that position, where you're having to make choices for somebody that you care about and you wish you knew what they really wanted, but you're guessing. So the time to have these discussions is early, and ideally when things are going well. So when you're healthy and able to communicate everything that's really important to you. If that doesn't happen, then great times to trigger the conversation are when things are changing. So you have a new serious illness diagnosis, or maybe somebody that you love does. Maybe you're in the hospital. There's been changes in functional status, the way that you're getting around at home, cognitive status, if confusion maybe is bothering you, or anytime you think, gosh, you know, I'm doing a lot of medical treatments, I have a lot of side effects, or maybe this just isn't working for me the way that it did before. So when we talk about advanced care planning, one of the big things we talk about is code status. Everybody's kind of heard code status, but what does that really mean, right? most of the time we think about CPR, and that's a big part of it. So if we're talking about a full code, what does that mean? So a full code would mean we're talking about resuscitation. So natural death has occurred, your heart has stopped beating, or you've stopped breathing. And that is the moment we are talking about. Not what happens right before that, but the actual moment where we need to intervene with resuscitation efforts. So that encompasses CPR, actual chest compressions, defibrillation using the paddles, vasopressors or medications to increase your blood pressure, and then intubation or ventilation using a machine to help you breathe.
Can I ask a quick question?
Absolutely.
Can you get the lesser of those done, or is it, this is full code, we're gonna do all of these or none of them?
Yep, we're gonna go on to that next.
Okay, thank you.
How about DNR, DNI? So DNR stands for do not resuscitate. DNI stands for do not intubate, so the respiratory part of things. There are folks who say DNR, DNI, I don't want CPR, I don't want intubation. There are people that say CPR is okay, I don't ever want to have a breathing tube. Then some people say I don't want CPR, but a breathing tube temporarily would be okay. So part of the reason we want to talk about this and document it is so that if there are those little things, that really matter to you, that's written down and your healthcare team and your family can honor those wishes. When we're thinking about DNR, DNI and making that decision, again, all typical care up to that point is unchanged. So, if you're injured and need help in any other way, all care is still delivered. If you're having a heart attack, and you don't want CPR, all care up to the point of CPR is still delivered. So no CPR doesn't equate no care. That is a big misconception and really worries people. So. There's details in here a little bit more about what actual CPR means. We talked a little bit about the chest compressions, ventilations, defibrillation, the shock to the heart. When we're making a decision about CPR, it's really personal. And when I give you all the facts about this and things to think about, it's gonna sound scary. And it's not meant to sway you one direction or the other, but our role is to make sure that you know the possible outcomes before you make the choice. So does CPR work? In the movies, yes, it works every time, always. And then you go home from the hospital the next day, it's great. It does not work like that in real life. So only about 9% of people who receive immediate CPR actually survived discharge from the hospital. So that's not at all what it looks like on TV, right? The success rate of that decreases pretty dramatically as we age. It also decreases with comorbidities. So the more health issues that you have underlying before you would sustain CPR have a huge impact in how successful that would be. And then if there's a delay in CPR, for every minute that defibrillation or using the paddles is delayed, the chance of survival reduces by another 10%. So that's pretty substantial when you think about, gosh, if you're in the community and something happens, that might look really different than if you were in the hospital and that happens. Are there complications from CPR? Yeah, there are. CPR is kind of brutal on the body. So there are rib and sternum fractures. About 81% of the time there are rib fractures, sternal fractures. There can be vomiting, aspiration, pneumonia, internal bleeding, collapse of the lung. And that's the physical stuff that can happen with CPR, but then there's also the stuff that hangs on afterwards. So there can be changes in cognitive or functional status because of those underlying medical conditions, the trauma of CPR, or lack of blood flow to the heart or brain. Sometimes that looks like movement disorders or changes in cognition, your ability to communicate. Sometimes those things go back to normal after recovery. Sometimes they don't. And we wish we had a crystal ball and could say, this is what it's going to look like for you if the worst happens, but we don't know. And so that's why we tell you about the possibility on the front end. So how do you decide if CPR is right for you? Like I said, it's personal. It's a hard decision. So there's no right or wrong answer. It's only what's right or wrong for you and your family. We think about your values, your preferences, quality of life, and that's a big one. So, I told you about the things that could happen. If those things happen, would you be okay with that? Quality of life is different for everybody. One person may say, absolutely not. I would never be happy in a nursing home. I would never be happy if I couldn't communicate. I don't want to live like that. And other people say, I want to be here no matter what that looks like. I want to be here. There's no right or wrong. It's really only what's right or wrong for you. And then your current health conditions, if it's me today, I might have a different answer than, 20 years from now. Things change. So good to keep reevaluating as you go along. So if CPR is not right for you, we want that documented, and you have to talk to your family about it. Putting it down on paper is one thing, but having it communicated is another. So your family needs to know, your healthcare team needs to know. These guys are going to talk about different kinds of advanced directives and how we can document that. And then briefly, the difference between palliative medicine and hospice. So that sounded like a lot of doom and gloom. The difference between palliative medicine and hospice is really that palliative medicine is available to anyone at any stage of illness and can be delivered while you're using aggressive treatments. So that might be chemotherapy or dialysis or radiation or blood transfusions for chronic anemia. All of those things would be appropriate for palliative medicine. When things change, if Medicare says that we have to have a guess that if your disease continues in its natural trajectory, we wouldn't be surprised if you passed away in 6 months. So that's the big difference between palliative and hospice. Both are covered by insurance, both private insurance and Medicare. They're both delivered by a team, and the hospice team has more team members than the palliative team does, and are able to support people in their homes and in a variety of scenarios. So if it's time to think about hospice, we can certainly help with that transition. Primary care providers can help with that transition, but really we start thinking about hospice when your goals are starting to change. So if you're doing aggressive treatments and you're thinking, gosh, I'm not tolerating this anymore, and I don't want to do this anymore, we talk about hospice. And hospice is another one of those things we want to talk about early, because the benefits for hospice are so much greater when we initiate it early. That's my quick blurb. I'll let you guys go next, and then I'll answer questions at the end.
This in here. I'm gonna let Sadie get my couple slides pulled up. So, like I said, I work in hospice care, and so thank you, Sadie.
Yep.
I think our community has been doing a great job of talking about advanced directives, and our providers too, because I'm starting to see more and more people come in with these things done by the time they get to me in the hospice circle. And so I'm really proud of our Avera team and the other medical providers in Yankton that we've made a lot of strides in getting the education out there so people can be prepared. So what I'm going to go through just real quickly here is just a few different types of advanced directives just to help get you a start in your planning. So I'm not a lawyer, I'm a social worker. If you have more specific questions, I would advise you to consult your lawyer for some of these more specific scenario questions, or consult your doctor. But I'm going to give you kind of a brief overview about where to start. So. Oh, it helps if I press present. You help me, Sandy. You should.
There you go.
Oh, there we go. Oh,
Yeah, sorry.
that's okay. So Melissa kind of went through what an advanced directive is. Basically, it's an umbrella term for a legal document that talks about your wishes for your medical care. Most of them pertain to if you're unable to communicate your wishes yourself, what are we gonna do? What's your family or your decision maker going to do about that? And how are we gonna implement your care wishes? So a couple of the ones that we're gonna go through tonight include a DNR, that's that do not resuscitate that Melissa was talking about, a medical power of attorney, a living will, and then a most or a post. So I'll explain what those mean as we go. The nice thing about these documents is they can be firm and set in stone until you don't want them to be anymore. So like Melissa said, as your status changes, as you age, maybe your family looks a little bit different 10 years from now, these documents can be updated, like I said, by consulting your doctor, your lawyer, or having them notarized again, an updated copy with those changes. So we'll go through kind of what it takes with each of them to get them changed and set up. But once you have these conversations, then you have it in place as long as you want it to be. So where I would encourage each of you to start, and kind of piggybacking too off of the first part, is just to reflect on what your personal values are and the values that you have within your family as well. So I put a couple questions up here to go through, just as you sit down to reflect on some of these choices. It's hard to think about. Nobody really wants to think about end of life care, but it's really important to help guide your family. So a couple questions to consider. If my prognosis is poor, then I want maximum intervention all the way down the spectrum to minimum intervention, which still includes comfort care and maintaining your dignity at end of life too. So there's a whole host of decisions within that spectrum, but I would encourage you to think about that. Another question, I want this person or these people to be involved in making decisions about my care. Who in your family or your friends, your community, who is important to you, and who do you trust with those decisions, if you can't verbalize that yourself? I want my death to look like what? And this is a hard one. Do you want to pass away at home maybe? Would you like to consider only passing away in the hospital or in a nursing home facility? You don't want to be at home. Do you want to have medical intervention provided to the fullest extent to your very last minute? Or would you rather be in a more, in a different setting with less people around and a little bit quieter? Like Melissa said, there's no right answer here. It's just what's right for you and right for your family. So I would consider that as well. And also, what final impressions do you want to leave with those who are closest to you? What things do you believe about life and death that you want to communicate to your family and your loved ones? What memories do you want them to carry with them about when you passed away? It's a pretty significant experience for each of us. I think we can all remember when a loved one or somebody close to us has passed away, and those memories really do make a lasting impression. So what kind of things do you want to leave with your family as you make these decisions? And that really ties in a lot of your worldview, your spiritual, religious beliefs. I would consider all of those things too as you're making these choices. So again, a heavy topic, but it's worth the time to consider. And all of those things will affect kind of your choices as you go through the different advanced directives. So again, start with some time to reflect. I would also have some conversations with your doctor and your healthcare team, your family and your friends. What are some of their expectations or what they thought you might choose for your medical care at this stage of life? And then also who you designate as your healthcare decision maker. And we'll talk a little bit more about how to do that too. But just having good communication is a great place to start as well. And then choose a plan. So we're going to go through some of these documents that are available to you to utilize and review with those who are involved in those documents. And then also just ensure that everybody has a copy. So your spouse, maybe a couple children have a copy. Bring it to your medical appointments. And we are blessed with so many different healthcare systems around here. Yankton Medical Clinic, Avera, Sanford, but they don't talk to each other very well. And so I would advise just bringing a copy to each of your appointments to make sure everybody has a copy of these documents in your chart. All right. So a few different kinds of advanced directives. This one is called the medical power of attorney. What it does is it designates a decision maker if you are unable to make your own decisions for yourself, or if you're unable to verbalize that to your care team. So a couple circumstances where that might happen. If you're unconscious, if you come out of it, wonderful, but there's been a span of time where you haven't been able to communicate what you want. And so this is where your medical power of attorney would apply. If you are in a state of cognitive decline, where you're a little bit more confused, whether permanently or due to medication or things like that, that may be more episodic. Or if you're terminally ill, if you're at end of life and maybe are not responsive anymore, this is where we would rely on a medical power of attorney. The document also allows you to designate alternates if the person you identify as primary isn't available. So it gives you a plan A and also a plan B and plan C. So it kind of gives your healthcare team a hierarchy of who to consult for your decisions. And why is this necessary? So in the state of South Dakota, the codified law outlines kind of a hierarchy of who they would consult if you don't have a medical power of attorney. It starts with a spouse, and then it goes to all of your adult children, and then it kind of goes down the line from there to other people in your family. And so it's great that we have that outlined in law, but every family is a little bit different and a little bit unique. Not everybody has great relationships with all of their family members. Sometimes there's estrangements, or you just maybe have a nurse in the family and you want her to be in charge. So a medical power of attorney is a great way to outline who you want consulted specifically without leaving it up to just the generalized law. Couple things to consider when you make a medical power of attorney. The person that you're going to designate as your decision maker, do they live close by or are they across the country? It doesn't rule them out if they live afar, but just consider they're going to have to be consulted by phone, and they may want to travel in closer if you're in a dire medical situation. Their health and cognitive status. If the person you're thinking about maybe has fragile health, I would really consider designating a secondary power of attorney in case that person isn't with us anymore, or if they have some maybe confusion starting. And then availability as well. If you have a son who works for the CIA and is undercover most of the time, I would not choose him for your power of attorney. He's just not going to be available when you need him. So a couple things to consider in the person and the people that you choose for that document. Power of attorney, it can come in different forms. What we're talking about is the medical power of attorney. There's also a couple different kinds, like the financial power of attorney and a durable power of attorney. So these two have to be completed by a lawyer. The financial one obviously has to do with who can manage your bank accounts, all of your financial assets if you're not able to. And then a durable power of attorney comes in different forms. Sometimes they have financial and medical language in them, sometimes just financial. So if you want either of those done as well, you can go to your lawyer for kind of the complete package of all of these. Otherwise, most providers at Avera facilities have somebody available who can help you complete a medical power of attorney. It's relatively simple as far as a form. And I brought a couple with me too, for South Dakota and some for Nebraska as well. So feel free to take a look at these up here afterwards. So, and then again, just communicating with your healthcare surrogates, your decision makers, what your wishes are. And we'll talk a little bit more about how to do that here. The other thing I just want to point out too is that you can designate multiple people for one role. So maybe you have 3 kids and you want them all to work together as your primary power of attorney. And that's wonderful. You can certainly do that. Just consider that when it comes to that time, say the hospital has to give your kids a call, they need to have everybody's permission, and we prefer everybody be on the same page with what their choices are. So just consider their relationships, and if you think that would work well for the people that you're choosing to act together as a group. So that's the medical power of attorney. If you do nothing else tonight, please think about this one. This would be the bare minimum that I would love to see everybody have, because this is usually where we start as providers and clinicians. Who do we consult when this person can no longer speak with us coherently? So this one is the first one that I would consider getting done. The next one is a living will. This one outlines your care preferences, and generally if you're terminally ill or in a vegetative state, if you're unconscious. So like Melissa talked about, things from intubation to artificial nutrition, hydration, blood transfusions, dialysis, that type of thing. It's a legal document to guide you, your power of attorney, and your care team regarding what kinds of interventions you want to have done. So things to consider for this document, just the spectrum of interventions like we've talked about. To what degree do you want your life to be prolonged or attempted to be prolonged? Or to what degree do you want to be allowed to just pass naturally? So there's a bunch of different interventions in between there. You have to decide what's right for you, but a living will can spell out some of those things. So the medical power of attorney and the living will, both something that we want to have in your medical chart that we can refer to. The next two advanced directives require, they kind of go a step further in getting your doctor on board. And so they're actionable a little bit more quickly because your doctor has already signed off. It becomes a doctor's order. So those will be the next two that I talk about. But the medical power of attorney can be done by healthcare staff or a lawyer. Living will, I would suggest having your lawyer help you complete. The DNR, Melissa talked about a little bit. DNR Comfort One, we kind of use the terms interchangeably. A Comfort One is a program that the state of South Dakota has through the Department of Health. They keep a database of everybody who enrolls. The Comfort One means that essentially you do not want CPR. And so you can order a bracelet to wear in the community that designates that status. And they also, like I said, keep that database at the Department of Health and the DNRs, and essentially a do not resuscitate order. So that means the doctor has signed off on your wishes to not be resuscitated with CPR. So I think I'll skip the rest of that because we kind of went into it a little bit more in depth, just considering the effect of CPR, quality of life afterwards, and the fact that you can still have comfort care provided to you and all the care leading up to that moment of resuscitation or not.
A quick note on the Comfort One, that's the South Dakota version. There's a Nebraska version as well. EMS is obligated to perform resuscitative measures if you are found down in the community, unless they have a directive that says not to. So, your do not resuscitate order in the hospital is your doctor's order in the hospital, but that doesn't follow you into the community. So if that's something that's important to you, you really should have one of these made so that EMS is aware of what your wishes are. And that follows you everywhere in the community, not just in a medical facility.
Is it something you carry like in your wallet, or do you wear it? Or
So typically we make a copy of it and we ask people to keep a copy like on your fridge. EMS knows to look for them on people's fridges. That's where we ask them to put them. We ask you keep a copy like in your glove box in the car. And then they do have identification bracelets that you can use. It doesn't have to say Comfort One on it, but those medical alert bracelets can be helpful also if you don't have an actual, card. I don't think they send you an actual wallet card, but it would be really nice if they did.
There's an idea.
Yeah.
Thank you for making that. Yes.
I didn't know about the bracelets. Where do you get them?
So you can contact the Department of Health. You have to order them through the state office in Pierre. I believe they're about $45, and they'll send it to you. So.
Even cost to die.
Yeah, so that's who you can contact with more questions about that. And your team too is great with helping patients get that set up too. So thanks for making that.
Just a quick question regarding being out in the community and you collapse and you have one of those forms on file. How does the EMS people know that this particular person laying on the ground has got a DNR, and let's just say, for instance, they don't have a necklace that day or whatever, what happens then?
So when the form is completed, it is sent to peer and it is sent out to EMS throughout the state. And so that's why it's different state to state. Each state has its own version of this. Nebraska has its own version, but when you're identified and EMS pops you into their system, you know, they will have notification that you do not want CPR. And if CPR has already been started when they've identified that, then they discontinue those measures and focus on comfort measures, if that's what needs to happen.
Thank you.
Good questions.
Do you have the contact information for that?
Yep, we can provide that.
The last one I'm gonna run through is the MOST, or the PULSE. This one is relatively new, and it came from legislation probably within the last 5 years that has come about with everybody just trying to get on the same page with how we keep track of our advanced directives in each state and between states as well. So in South Dakota, it's called the MOST, the Medical Orders for Scope of Treatment. In Nebraska, it's called the PULSE, Physician Orders for Life-Sustaining Treatment. They're relatively similar in their in what they contain. So this one also is a doctor's order. And I have a couple forms with me. I have a few more resources about this up here. I have an actual MOST form, and I have a couple brochures here as well. I would really encourage utilizing your doctor to go through this form with you because it is so extensive, but it combines a DNR and a living will together. So some of those preferences on how much intervention you want. Do you want CPR? Do you want artificial nutrition and hydration? It combines all of those things together, and then it has your doctor sign off on it. So it becomes an official order that's actionable in your chart. So it's pretty extensive, but it takes care of a lot of things in one. So we're not seeing a whole lot of these in our patients' charts yet, but we're starting to. So we're trying to get the education out there because it's really helpful to get everybody's wishes all in one spot and have your doctor on board as well. So typically the most, I believe the verbiage in it only applies for patients who are terminally ill. So if your attending physician believes that there is not a good chance for recovery from your status, then this is when these orders would be implemented in your care. So if you come in with a broken arm, you don't have to worry about not getting treated because you signed a MOST. It's not going to be effective in that situation. It's only if you are terminally ill. So if your doctor doesn't know much about it, that's a great chance for them to educate themselves too. But South Dakota has a great website that I have on this brochure here with a lot of information on it, on the MOST. So we're trying to get the education out there about that. So like I said, a couple things up here to pick up after we're done. This is a flyer specifically about the MOST advanced directive. And this is the actual MOST document there. And then I have power of attorney documents. If you're a Nebraska resident, you'll need that one. And I have South Dakota ones as well. These have to be notarized. So I would encourage you to take it home, look through it, think about who you want to name as your surrogate decision maker, and then bring it back to the bank or whoever you know is a notary to make that official for you. And then these brochures, I would like everybody to take one. It goes through all of these things kind of in one spot. So I know this is a lot of information and it's hard to keep track of, but this is a great resource for kind of reviewing afterwards. I think that is all I have. We made it through. I'll pass it over to Sadie.
And I will wrap it up. So we thought how we were going to tie this all together. We thought hospice was appropriate to have at the end because a lot of the time hospice is kind of the last step. It starts with a referral from usually a provider. And then a lot of the time, sometimes people who I get hospice consults on, they don't necessarily have a will or a DNR or any of the advanced directives set up. So just know it's okay, but it's always nice to have. I'm going to tell a quick 30-second story about something that made me think of this. We had a family member I visited in the hospital, not my family, it was a family in the hospital, and I visited with him. He was very cognitive, able to make his own decisions. And over the days, he was not. And so the default came to his kids because his sibling or his wife was not there. I think they had a handful of kids. I can't remember, but it was a few. I could not get a hold of a few of the siblings, and it was taking days. I remember I went to the social workers and I said, what do I have to do? Because he really wanted it, but now he's not able to make this decision. And I think you guys told me it's a consensus, right? So
Between who we can reach.
yeah, because sometimes it can take days for a sibling to call back, and sometimes they don't want to call you back anyways. So just something to think about. Where I fall into the picture is a lot of the time I start talking with people, whether it's in the hospital, the nursing home, in their home, wherever. I always start by I have to have a physician's order, a doctor's order, or a provider's order. Sometimes Palliative will send us referrals, and that's where I initiate the conversation. What is hospice? And then I go from there. Sometimes, in most cases, people have had these discussions with their providers and they've made the mind up to go the comfort route. And so it's easier on me when I visit with the family members because they've made that decision, but there are times that they haven't actually had those conversations, and so we're trying to help them figure out if hospice is the route they wanna take. And so I'm just gonna start, there's misconceptions about hospice that I hear all the time, and I hear this all the time. I feel like I'm giving up. If I go on to hospice, I'm just giving up. And I'm just gonna say, it comes back to what they were saying, your decisions and what are personal to you. Do you wanna focus on comfort? Are you tired of aggressively treating? Is there no options for treatment? Or maybe you just wanna focus on comfort and your quality of life left. And so that's okay. Hospice is not giving up. It's really when you come to I guess the terms of I want to be comfortable. And that's really what it's about. It's a place, a lot of people think that hospice is, we're going to come in and take your life right there. I've actually been asked if I was there to give the shot. And I said, oh, no, that's not what hospice is. We're very much a comfort approach, but we've seen people improve, their quality of life improve, and we've seen them even do better on hospice. There are also, people that think it's only for people with cancer or only for people who are emergently dying, or near that, right at that end of life. And that's not the case either. There is criteria that you have to meet for hospice. Not everyone can just say, well, I think I'm ready to go. I think I'll sign up for hospice. It really doesn't work like that. You have to be showing the need for hospice. You have to meet the criteria. And a lot of that will come down to you and your providers. And when I get the order, we dig into your records, and then it's still an approval process on hospice's side. So we're sending to our medical director and making sure that you are in fact appropriate for hospice. You do meet that criteria. So we follow Medicare guidelines, and what that is a physician has to attest that you have 6 months of life or left expectancy. It doesn't mean that you have 6 months left to only receive these benefits and you have to make that decision right now, and in 6 months, if you're still around, you're gonna lose that. It does not mean that. We've had people on hospice for years. We've had them graduate from hospice. We've had them do, like I said, do better. And then we've had them have short times with hospice, and sometimes they change their mind and they just no longer want hospice, and that's okay too. So hospice, it focuses on comfort, so not curative. So as Melissa said, when you see palliative, you're still very much And maybe you're not, but you're in the treating curative stages. You're just trying to figure out how you want to manage your illness. Whether or not you decide to start hospice right away, you can still stay on palliative if you're still wanting to treat and you're not quite sure if you want to stop and focus on the comfort route, if that makes sense. It's really a comfort approach that uses a team to come in and help you manage your symptoms wherever you are. I'll just go on the next. So who is eligible for hospice? Anybody that has a terminal diagnosis. And it doesn't mean that, because a long time we see people with terminal diagnoses that they can live for a long time, years. When you're given a terminal diagnosis, it goes back to a physician or a provider, somebody that feels that you have 6 months of life or less. The expectancy, it's just an estimate, a guess. Like I said, you don't have to necessarily meet that. And we see a lot of people, so dementia, COPD, strokes, people with end-stage renal failure. We see a lot of people that have those qualifying diagnoses, but it doesn't necessarily mean that they are eligible for hospice if they still want to continue to treat those aggressively. Let's see. Sorry, so when I have these visits with patients, I usually visit with family and I don't go off of PowerPoint. So I'm not a PowerPoint person. You can tell I'm just a talker. So it does require a physician's order, and it does require your power of attorney's assent. So your medical power of attorney, if you are not able to make those decisions, we do have to have consent from your medical power of attorney, and that's why it's really important that you designated somebody who you think will respect your wishes and make the right choice based on what you wanted. And on our team, it's very similar to palliatives. We've got a little bit more extra. So this is what I love about hospice. We can go anywhere somebody calls home, whether it's in a nursing facility, in your home. It really is anywhere that you call home. The team is going to be a nurse, an aide, a social worker, a chaplain. There's going to be people behind the scenes that you're probably not going to see as often. The medical director and the pharmacist, they are there to help guide the team and help manage behind the scenes. So they might make suggestions to the nurse when she comes out. She might say, so-and-so is experiencing these symptoms. We've tried this. How can I get them more comfortable? Do you have any suggestions? And that's where the pharmacist and our providers on the team are going to step in. And Melissa, I will just say, Melissa's actually one of our hospice providers. So she's really good about coming in and helping on. They're really good, and the team is always available to help the nurses if there are anything that we can't, get the person comfortable right away. The nurse is really there to help manage symptoms, to educate the family, to provide support to the caregiver, so that way everyone feels comfortable. Maybe some families have multiple caregivers, and so our team is there to help everybody. And it's not just the patients, it's really for support for everybody involved in that person's care. If they're in a nursing facility, we want to help the staff at the nursing facility. It's a team approach, with the overall goal is to keep someone comfortable. The social worker, as Michelle's one of our social workers, I can't even begin to tell you how many hats the social workers wear. Just everything. So they're very focused on quality of life. They're focused on the family, the patient, and they're very helpful with many things. It could be maybe you start hospice in your home, and maybe the caregiver is getting burnt out. Maybe they need some extra support. The social worker is a great person to come jump in and say, hey, let's do this. Let's see what we can do to help provide support for this person and this patient. So the social workers wear many hats. Our chaplain, we have a few chaplains on the team. They're not there to convert your faith. They're really there to provide that spiritual support. And that could be different for everyone. So he's wonderful. I got to shadow him for a day. He's just really great. Sometimes you are getting spiritual support, just having conversations, letting go of things, or for talking about things that maybe you carried on through life and never spoke about. Chaplain, he's just a wonderful person to help you with that spiritual support part of your journey. And volunteers, we do have volunteers. They can come and sit with you. They can come and, like I said, if the caregiver has to go to the grocery store, or maybe the person doesn't have a lot of family, our goal is to kind of fill in and jump in and help become like family. We use volunteers for many different reasons, and it's really what does the patient need, and how can we support them better. And then we have a bereavement program. So after somebody ends up passing, we do have a program that follows the patient or their caregiver or their family members for up to 12 months. And I think sometimes we'll even say longer, just depending on our social workers are in charge of that. But it's really depending on how that person, their needs and what we can do. And then does hospice help? Yes. How does hospice help? So our nurse is going to develop a care plan based upon everyone's individual need. Like I said, it could be a husband and wife who are living at home, or maybe just one person. Maybe it's just one person and they need a lot more support. That nurse will determine how much support. So do they need aides every day or up to 5 days a week? Is there a certain part that we need to focus on? Do they need some Meals on Wheels, or do they need more help where our team can look and fill the gaps? The nurse will really work with each patient individually and develop a plan based on their needs. We provide medical equipment. We provide all the supplies, all the medications. Some medications, and this is tricky, some of the medications that are not covered on hospice, they still can be ran through insurance or privately paid. Some people, it's important that they continue certain medications, and that's fine. Our pharmacist will weigh in and talk to the nurse about any suggestions that they feel. Maybe there's something that's not necessarily has short-term benefits. It's more for if you're on something for longer, is it really necessary to keep this, or is there a generic version that we cover, or something that we know that works better for certain patients? And like I said, it comes down to the whole team being involved. The pharmacist, they really weigh in their 2 cents, and they see a lot of people with similar diagnoses, and they're able to look at what worked best for some of these patients and make those suggestions. And then we provide information on the dying process. That's where our team will come in and help you guys. We will help caregivers, patients, we'll help support them throughout that. We'll help them understand what to expect, what's not to expect. We have literature. And again, it's a team approach. You guys, we want to treat everyone differently, because everybody has different needs and different ways of learning. And so whether it's a visit from the social worker, or maybe you just want to read some literature, we can provide any of that. Trying to make this fun. I know this talk, the hospital talk. Sorry, you guys, I'm trying really hard to. So basically, just know this, it covers 3 things. It covers the people, the equipment, and the medication, okay? So you get the people, the team, you get the medications that are here to keep someone comfortable and related to what is causing them and their decline, and then all the equipment. So it could be hospital beds, oxygen, it could be wheelchairs, commodes, really anything that you guys need. It could be a bedside table when you're in the hospital, those tables that go up and down. So that fun stuff. And then I think I got the hard part of the discussion. So like I said, you get nurses that are gonna visit regular, depending on your needs. If you're having a good week, the nurse might only visit once, but make those phone calls. Or if you're having a good week and you still need a nurse at 2 a.m, there's 24/7 on-call number that you can call. And our goal is to make sure that we're there all the time. We might not drive out to the house just for a certain thing at 2 a.m, but we're gonna help you on the phone, and if we have to, we certainly will, okay? And then again, the emotional, spiritual, psychological support, the bereavement care, I think I touched base on all of that. I will tell you this, I don't know if anybody's ever heard of respite. When I have consults with people, a lot of people don't know what respite is. When you are on hospice, and let's say you're in your home, let's say the caregiver gets burnt out or fatigued, or maybe they have a medical situation that they need to address. On every benefit period, you're entitled to, and Michelle, correct me if I'm wrong, 5 days of respite care. And that is when you can go into a facility such as Sacred Heart Hospital and use their room and still get the help of the staff and our staff, correct? That way that person, the caregiver, can either have a break, recoup, or take care of what they've got to take care of during that time. And it could even be if they have to go to a graduation or something. Right. Yeah. Yeah, so that's what respite is. I get that question a lot, and I've had to reach out to the social workers to make sure I'm explaining that one right, because that was a new word to me too. And then where is hospice provided? Again, wherever you call home. If you're in assisted living, if you're in the nursing home, if you're in your home, we can come. There's one thing we do require. If you are in your home, if you're doing fairly good, we'll come and help you if it's just you. Our social workers may talk to you about a plan B, just in case you're not able to care for yourself and you might not have somebody 24/7. But that's just know that we can start always in the home. We could transition to a facility. We could start in a facility, transition home. So it's wherever you call home. And our goal is to meet your guys' goals. So wherever your loved one wants to be, we're here to help figure out how we can make that happen. And hopefully with our support, and hopefully our support is enough that you guys feel comfortable if you do decide to stay in your home. Hopefully it's a good amount of support for you. And then what to consider with dying at home. This topic is, I feel like, I'm so sorry, you guys. I feel like everybody's just looking at me like, what a topic. So it's nice, everybody, I think a lot of people, the majority of people want to be in their home for as long as possible. And that's why we're here. Sometimes if you've got something going on and it's not likely reversible and you want to stay in your home, sometimes our help is what you need. And we can keep you home longer with the help of our team. So again, things that you have to consider is, do you have somebody available to caregive in case you're not able to take care of yourself? So think about who would be your caregivers if that's something you did want and to be home. What is your plan B? Are you able to afford a nursing home? Is being at home going to be a better alternative plan if you don't have finances set up to go into a nursing home? Sometimes people like hospice because we are able to go into their home. It's where they want to be, but they also save some money out of their pocket, and that's okay too. Family dynamics, these are things to think about. We see a lot of different things. So if you think you've got some family dynamics and being in your home won't be a peaceful experience with them, sometimes it's just nice to think about where you feel you would want to be if that time comes, or your loved one. And then of course, safety issues or concerns. It goes back to, do you have a caregiver in case you cannot take care of yourself? We don't want anybody to fall or get hurt or not have someone there to help them if they got to that level and they needed help. So these are just things to think about. if you wanted to stay in your home, things that we are looking out for too. And then just what's your plan B? And sometimes when I go visit with people, they don't have a plan B. That's okay too. Our social worker is very good at coming in and helping them figure that out. And then who pays for hospice? So I'm just gonna say this. Hospice, regardless of your payer source, your financial source, Avera at Home will not turn anyone down if you do not have insurance. Medicare does pay for hospice. It pays for the people, the equipment, the medications. It does not pay room and board in a nursing facility. But we are not going to turn anybody down. And that's the beauty of working for Avera. The sisters won't turn no one down, and I love it. But we will not turn anyone down. So when I say pay, don't feel like you can't get hospice if you don't have Medicare or if you don't have an insurance. It's okay. Medicare does pay for hospice. Medicaid pays for hospice. Private insurances pay for hospice. And then again, Avera does have a charitable foundation. That is what their ministry is based on. So their mission, and they have ways that we can fund for hospice. We do have a hospice house here in town. It is at Majestic Bluffs. It is a private pay. And just recently, the foundation announced that they would be, I might get in trouble if I say this, it's an application process. If you don't have the funds to pay for it, there is a process that you can fill out an application with a social worker. You or family members, depending on who, can pay to see if you'll qualify for the hospice house to be covered. And the hospice house is they're beautiful suites. They're actually bigger than your typical hospital room. They have an extra living room and pull-out couch where family can stay, little kitchenettes, and it's just a little bit more personable. So just know that is an option too. And I'm happy to say that recently the foundation has said that they'd be willing to help people out who couldn't afford to go into the hospice house. Sometimes we run into people cannot afford to go into a facility, but they need to, but they cannot afford it. And our help is not enough for them at their house. They're just needing more. So that hospice house is a nice option that we have. Okay. And then, I can let you talk into this. I don't know that we need to go too much in depth on this. I feel like we're very much over. So let me just have Michelle wrap this up. I don't know, do you think we need to go into the grieving?
I'll just mention that, like you said, for our bereavement services, it's kind of continuation of our hospice team's interaction with your family after the hospice patient passes away. So during that time of the loved one on hospice, we've identified somebody to continue communication with after they pass. And so we'll give you a phone call about every quarter for the first year and some things in the mail. And our role is to just kind of assess how you're doing in your grief. Grief takes a lot of work. It's not a passive experience. You have to work at it. And so everybody's death experience is a little bit different, how they view their loved one's death. And so some of it can be a really positive experience, and you can still have a tough time grieving. And sometimes it's a really tough experience, and you still might be doing okay. So that's up to us to assess and to recommend resources. Our community is wonderful with the funeral homes and our church communities in town as well to offer bereavement and grief support more extensively than what we offer. But we're kind of the first line filter to tell it or recommend if you're needing some of those extra support resources.
And the rest is just a recap. I don't think we need to recap that. But I hope you guys kind of got all the information you need and understand how we intertwine with each other. And we are happy to answer any questions. If anybody is interested in a more one-on-one conversation about hospice, our Yankton office is right here. If you are question, if you're questioning whether your loved one qualifies or maybe you qualify, again, talk to your provider. But our Yankton phone number is on here, and feel free to grab whatever you guys would like. We appreciate your time. Thank you for staying with us. I know it's tough at the end.
I just have a question about the bracelet you were talking about, that you fill out a form or whatever, it goes to state. How does that differ from like the little forms that you might get at the pharmacy?
Doesn't
Kind of
really,
the same as long as you're wearing something that says do not possess
Correct.
or whatever?
Correct. Yep.
May I make a comment?
Uh-huh.
For the price of a bracelet, it's priceless. I have one.
Do you?
It's a lousy $15.
Yeah, you
And
can,
when something happens to you on that spot, time is everything. Who's got time to call this and call that and call that?
Yeah.
That ambulance guy knows right there.
Yeah.
And then they know who to call.
Right.
Yep.
Boy, folks, I recommend this 1,000%.
You're our new spokesperson.
My daughter got me one. And it's a good feeling. I mean, how can you beat it? It's an insurance policy all paid up.
Well, Christmas is coming up, so if anybody wants to do that. Yeah.
We're not selling those either. I don't want you to feel like we had them
Put it on
from
your
here.
neck.
There you go. Come on.
Is hospice available out of Yankton? I don't.
Yes, you know what, I'm glad you actually said that. So I didn't put this on the slide, but I want you guys to know hospice is everywhere, Whether it's Avera at Home, there are several agencies. Avera at Home in general, so we cover everywhere from Gregory clear down to, almost Norfolk, Nebraska. Clear out to Vermilion, and then Sioux Falls, pretty much everywhere. We're all over Aberdeen. We're pretty much in the South Dakota footprint. And when you talk, to other hospice agencies, if you ever do, hospice across the board is very similar. And so, they might offer different services, like different aid amounts of time, but the overall goal is a comfort approach, and it's very holistic, spiritual. It's just, everybody gets a large amount of support, so it's a good thing. Good thing. Yeah.
Do you know of any care facilities or providers that are trained to care for HD people? Huntington's disease?
there is a neurology palliative provider in Sioux Falls that does,
Dr. Person?
what's that?
Is it Dr. Person?
He's actually a palliative provider that specializes in neurological disorders. His name is Dr. Jarris, and he's at Avera Palliative Medicine.
He is actually our medical director for hospice. I like him.
What kind of doctor is he?
Palliative medicine,
Oh, okay.
that thing I was talking about at the beginning.
Yeah.
Sorry, yeah.
It's that, yeah.
Otherwise, do you know of, have you guys dealt with Huntington's in your work?
Yep, I can recall having a few Huntington's disease patients. So
Okay.
Part of the beauty of having a team together is that I feel like I'm learning something new every day with our providers working together, and we've got meetings all as a team. And so if we don't know something, we've got a lot of resources to consult about how do we care for this person as their disease progresses. And so it's, there's a lot of teamwork that goes into it, but yeah, we've taken care of people with that diagnosis, a whole host of others.
Are there certain facilities that will take them?
I believe the resident I had was at Avera Sister James that I cared for, so the Majestic Bluffs campus, the nursing home out there, but yeah.
I know most of them don't, especially if they have behavioral issues,
Sure.
because they're not safe to be around the others.
Sure.
Yeah. And when we do those evaluations to determine that, because some people, just aren't, if they have a lot of behaviors, some people can, they can be the word I'm talking, manage well. So it just depends. Dr. Jarris would be a good person to talk with to see. Sometimes the providers will work on figuring out ways to get them managed, and then we'll go the facility route, seeing now that they're managed, can we get them here?
I know that HSC takes Huntington's people and the Mental Olivet Care Center.
We provide hospice up in Minnow. HSC actually has their own internal team that provides comfort care within the facility, so. Questions?
You guys are welcome to